Good afternoon. It's now afternoon. I'm Tom Strouse. I am a psychiatrist and a palliative care clinician who spent the last 25 or so years working almost exclusively in cancer. And I am a clinician teacher more than a scientist. My views and my perceptions have been formed by stories, and I will tell you a few of them as we go along. The American Board of Internal Medicine insists that I show you this. I chair the test writing committee for hospice palliative medicine. There will be no answers to test questions. The other conflict, I guess, or the disclosure I'd like to make is that although I think of myself as neither a proponent nor an opponent, I did and do actively participate in UCLA's way of addressing the California law. I helped craft the policy. I serve as one of the mental health professionals who evaluates patients. I'm not a prescription writer. But my views really have been shaped also by 2 gun suicides in patients I've cared for the last 25 years, both cancer patients, both men in their 60s or 70s. Dismissive attachment would be the understatement. When I began to read Lynda's work, I realized she was talking about these guys. These men did not have mental illness. And this was all before the California law. So I think of those as probably the worst outcomes for everyone involved. The patients wound up achieving their goal of being dead, but I think in a way that probably could have been better. And that doesn't mean that people should intimidate us into writing prescriptions with their suicidality, but it's simply part of how I think. Okay. So a little history. President Napolitano, I think believing she was enacting the will of the legislature and therefore the will of the people, directed all 5 of the UC health systems to write policies. We did that. I'm going to be talking now about terminology that can be vexing. So mental disorder, impaired judgment, voluntariness and coercion, a little bit more about clinical approaches to decision-making capacity, although Scott did a very nice job and I'm not going to probably be able to add much, and then my view of maybe some evidentiary gaps. So in California, by the way, when does the attending physician refer to the mental health professional? And this is directly from the law. If there are indications of a mental disorder, charmingly archaic language, don't you think? Mental disorder? None of us actually use those terms, but that's what's in the law. The physician shall then refer the patient to a mental health specialist for assessment, and if that mental health specialist happens, before it happens, full stop, no aid in dying drugs shall be prescribed. So this is very much like what exists in the other states. California law actually doesn't describe mental disorder. I had the UC attorneys look because I couldn't find anything. Rather, it refers to whatever is the current version of the DSM, the Diagnostic and Statistical Manual, as its source. And so I think we can live pretty reasonably with that. What is a mental health specialist? It's either a psychiatrist or a licensed psychologist. Again, pretty unremarkable. And then what happens? So I thought I'd actually show you the text in its old print just for fun. Upon referral, what does the mental health specialist do? We examine the qualified individual and his or her relevant medical records. We determine that that person has the mental capacity to make the medical decision, to act voluntarily, and to make an informed decision. We determine that the individual is not suffering from impaired judgment due to a mental disorder. I don't think Lynda or I or any other psychiatrist in the room was ever taught during our training to evaluate for impaired judgment due to mental disorder. Probably the closest thing we come to doing that is making involuntary hospitalization decisions, but that's much more specific. That's about generally whether people can provide for their food, clothing, or shelter as a result of a mental disorder. And I'm still not, as you said, Lynda, I'm still not sure I know what this means to do, but I'm going to do my best to describe my thought process. And then in California, capacity means a person's ability to understand the nature and consequences of a decision, to make and communicate that decision, to include, in the case of proposed health care, the ability to understand its significant benefits, risks, and alternatives. Pretty garden variety stuff. I'm not going to read you these details because you've already heard them. So at least in my construction then, the mental health professional actually has 2 things to do. One is to review and determine that the patient capacity to make medical decisions, act voluntarily, and make an informed decision, verify that that's the case. And 2, to discern whether or not the patient is suffering from impaired judgment. And the law actually doesn't tell us about what, but again, we infer impaired judgment related to the crucial decision at hand. and whether that impaired judgment is due to a mental disorder. So to do that, you have to first decide whether mental disorder is present, then evaluate for impaired judgment, and then try to causally link those two things. Again, no recipe, no guidelines, no standards that I know of to assist us in doing that. So I went to a few sources, including the Oxford Dictionary, although Wikipedia does a pretty good job too. Impaired is weakened or damaged, having a disability of a specific kind. Judgment, the ability to make considered decisions or come to sensible conclusions. Okay, maybe that's about as fine a definition as we're going to arrive at. I thought I would just construct, since I haven't seen it elsewhere, some scenarios. These are not from real life, but just examples of what I might think was impaired judgment due to a mental disorder. So this might be somebody who's severely depressed, who has delusions of deserving punishment or death. I think we could probably agree that person has impaired judgment due to a mental disorder that might bear directly on a request for physician aid in dying or access to lethal prescription. A patient with advanced dementia who cannot recognize the impact of his or her behavior on others. A chronically hypomanic patient who's with recent impulsivity and an inability to appreciate the consequences of most actions, including, again, in this case, a proposed access to lethal medication, or a polysubstance-dependent man who has been impaired enough in recent years by his addiction so as to have been unable to make other important life decisions. Again, these are just made up. These are not people I've seen under the setting of the law. And although I don't want to belabor it, I do want to point out to you that the statute in California actually does lay out a definition of an informed decision directly pertinent to physician aid in dying. Voluntariness for medical consent, again, I think there's something of a consensus in the field. Most would agree that it requires two conditions: intentionality and freedom from controlling infants, is often described as coercion. But I think that we have not really given adequate attention to the following question. Could it be that voluntariness to consent to a proposed procedure, you need an appendectomy, you need an amputation for gangrene, is different than voluntariness to request a desired procedure? Now in Los Angeles, that's usually plastic surgery, but here, of course, we're talking about a request for a procedure or for a treatment with the ultimate consequence, because again, we presume the patient's goal is to be dead, and that would be the result in almost all circumstances. I think those are fundamentally different, and I think this is one of the major areas where we need to know more than we currently know. Just an outline of what the California Medical Board advocates as, and what is pretty close to our standard approach to the mental health evaluation, which, as has been alluded to, includes mood and anxiety screeners and a cognitive screener, but as well as a detailed exam. And I would add that one of the things that helps me feel more confident is, as been alluded to here, when I see these patients, or my colleagues in psychiatry see these are patients who have been looked at and are followed very closely by a very large network of caring, attentive folks, what you might call in most systems navigators, who have done extensive individual and family psychosocial assessments. So I think the work of Lynda and others has pointed out that there's reason to be concerned that a single 1 or 2 hour evaluation by a mental health professional might not meet a standard that we would all feel very good about of assessing capacity. But I think in many settings, certainly in ours, it's a much richer fabric from which we draw information that leads to decisions. Coercion, again, generally construed to mean undue influence by another person or entity. Some scholars posit coercion by the illness itself, that is either cognitive difficulties, mainly disordered insight, or mood disturbance. And again, I think this coercion by illness might be another way of saying things that you've already heard from other speakers this morning. Garrison, in a law review article, actually advocates a whole different set of standards, which the lawyers in the room and the scholars in the room might be interested in, but I will leave it at that. Of course, capacity versus competence, as Scott said, these are probably synonyms, but generally we health professionals think of ourselves as assessing or doing clinical evaluations of capacity, and we sometimes allude, only when the courts get involved, to competence determinations. I don't think the legislature expected that the court was going to get involved in capacity evaluations in the California End-of-Life Options Act, and I'm unaware of any examples where that has happened, but I expect it may come soon, particularly if there were profound disagreement. And again, this is probably old news for most of you, but a capacity assessment typically agreed to have the following components: the assessment of functional abilities, the assessment for the presence or absence of psychopathology, evaluation of the complexity of the task demand at hand, the consequences of the decision. Again, these are very high stakes, of course, in physician aid in dying, and then reassessment or the evaluation of the durability of the decision. Applebaum and Grisot really are seen as, in many ways, the pioneers of this four-component model, which includes understanding, appreciating, reasoning, and expressing a choice. And there's lots of scholarship here. I don't think it's useful to go into it in detail. There are some instruments that are used to aid this. Actually, Applebaum and Grisot created the MacArthur Competency Assessment tool during a Genius Grant year. But there are others, and in fact, at least in some evaluations of their durability and their reproducibility, the MACCAT doesn't do as well as actually the ACE, the Assessment of Competency Evaluation, is the one that emerges, at least in this article, as the one with the greatest inter-rater reliability and the greatest ease of use. These were studies done in hospital medicine inpatients who probably are at risk for impaired capacity. This is the ACE. It's available on the internet. You can download it for free. You can get trained in using it with the related materials, just in case you're interested. But again, I think that all of these tools have been organized or conceived around affirmatively offered proposed treatments. That's when we get worried, when patients are either declining, we think of something as entirely reasonable, or sometimes we worry about this on our geropsych inpatient unit, are agreeing in ways that we think are tacitly, or excuse me, are clearly incompetent. For example, you can't consent to ECT if you're psychotically depressed in California if you lack capacity. That's probably a good protection. But I think that, again, a patient-initiated request for physician aid in dying is a different creature. And I don't think any of these tools have been organized around that basic set of issues. You know about these cross-state similarities, and I'm not going to belabor them. I'm going to finish just with a few stories. So we have seen, I and a couple of other colleagues now, 10, although I only have vignettes for these, 9. 2 of them died of natural causes before completing the algorithm and before completing the mental health professional exam. 5 received an aid in dying medication after the mental health professional exam, of whom 3 ingested and died. 1 is currently holding the medication, and 1 is pending prescription. 1 patient suicided prior to really completing the algorithm, prior to being seen by the mental health professional. I did not know that patient, but my hunch is that he was another dismissive attachment type guy who was simply not going to wait around. And 1 lacked capacity. That was somebody I saw who I'll tell you more about in the next story. So just 3. 6-year-old Latina, 12-year history of metastatic breast cancer, widespread metastases to bone, contralateral breast, lungs, abdomen, and brain when I saw her. She had begun talking with her medical oncologist actually about 6 months before the California law was active about physician aid in dying, in recognizing that she was approaching end of life. She described an even longer deliberative process, actually going back to a decade or more, when she might prefer what she called rational self-delivery if she had a terminal illness and unacceptable quality of life, which for her had very specific definition: inability to garden, inability to socialize, to read, crochet, pursue her spiritual practice, which was very profound for her, and which she was able to do when we met. She did not have mood or anxiety or psychotic symptoms. She, both by screeners and by more formal depth testing, had no evidence of impaired cognition or other evidence of impaired capacity. There was some concern that her brain metastases could have an effect there, but did not in any demonstrable way. And she went on from the mental health evaluation to get lethal prescription. Another patient, 56-year-old African-American woman with metastatic breast cancer. So by the way, I've already told you 2 scenarios of people who don't seem to look that much like the older white guys in Oregon who have a high degree of education. You know, one of the big public health kind of policy questions was, what are the 40 million people in California going to look like? And this is hardly science. This is not statistically significant. I'm just saying these are the patients I saw. So this is a woman who actually had come back to California as her metastatic breast cancer progressed, and she had developed hypercalcemia in the hospital and had newly diagnosed brain metastases. And it was immensely important to her and her family that she pursue physician aid in dying. even though when I went to see her at home, a day or two after her request came in, she was already unconscious and never woke up. And of course, because she was unconscious, she lacked capacity, and that was that. And yet, and I think this actually characterizes all the interactions I'm telling you about, her family experienced this as a profoundly important clinical interchange in which I sat with them and this unconscious patient and talked through both what her wishes had been and what the law required, and explained to them why she didn't qualify. But they felt quite, I think, positive that she had gotten everything she had asked for in terms of scrutiny and the possible consideration of that. Another woman, this is a woman with advanced Parkinson's who had a profound progression of her disease, required, Joanne Lynn was describing this woman, both in terms of her frailty and her requirements of care by others. Also had a number of other burdensome symptoms and chronic musculoskeletal pain and hypophonia and dysphonia and actually some swallowing difficulties. So in the room, rather starkly, her neurologist asked her to demonstrate that she could swallow 6 ounces of liquid, which she succeeded in doing. She was an evangelical Christian who had puzzled and struggled for years about how or why a merciful God could allow this to happen, and she would never have considered self-delivery by any illegal or self-directed means. It was incredibly important to her that she have a legally obtained prescription. She did not have depression or anxiety or a demonstrable cognitive impairment, and again went on from the mental health evaluation and did get a lethal prescription and did ingest it and did die peacefully. Anyway, I'm going to spare you the final vignette and go on to our early impressions. The folks we've seen at UCLA describe reasons for seeking physician aid in dying that seem very similar to those reported more formally from Oregon's public database and also from what we've heard from our colleagues here in the room this morning. Those reasons focus on durable, long-held health values, personal perspectives on quality of life, on desire to control the time and place of death, on their wishes to avoid prolonged disability, dependency, suffering, and future symptom burden. Generally, my sense is the referrals are made out of an abundance of caution, and it was alluded to earlier that there's a learning curve when a system takes something as complex as this on. So I think, I'm not sure if this is good or bad, but there were more referrals early in the first year than there have been in the last 6 to 8 months. Often these are folks who simply had a history of mental disorder, or at least the fact that they were on maintenance citalopram made somebody think they had a history of mental disorder. And judging from the standards which are used to start people on antidepressants these days, that might or might not be true, but that's another discussion. But they did not have demonstrable mental disorders when I evaluated them, or my colleagues evaluated them, not currently active symptoms. And impaired judgment due to mental disorder, that creature which we've yet to specifically define, has thus far not been a disqualifier for these patients. So again, I'll finish with this comment that physician aid in dying, perhaps different criteria are in order than for other medical decisions. The patient's goal in physician aid in dying is typically death. The patient's goal in other kinds of medical decisions is typically some other health outcome. Who initiates the discussion? Well, with physician aid in dying, it's the patient. In other medical decisions, it's almost always the clinician, although with the plastic surgery exception, it might be the patient, and there are probably other examples too. Capacity and consent process specifically outlined by state law. With physician aid in dying, certainly yes, not so much in other settings. Mandated reporting, yes, and PAD, no, in others. Mandated consultant MD, absolutely yes. In physician aid in dying, only sometimes, particularly if the plastic surgeon is very uncomfortable with the request, then they might get somebody else's input. These are perhaps two local examples, excessively local examples. A mandated mental health evaluation, of course, yes, if there's evidence of mental disorder, and sometimes in some of these other settings. So I'm finishing 50 seconds early. I just wanted to express appreciation for the support for my efforts. Thank you all very much.